Good afternoon and welcome. My name is Marissa Lozano. I'm the Director of Community Education here at the Muscular Dystrophy Association. Today's session is part 3 of our gene therapy series, which has been focused on advancements and considerations in gene therapy across neuromuscular diseases. We hope this series will provide the patient community with a greater understanding of the topic and that it will empower you to make informed decisions about your care or your loved one's care. If you missed the first 2 learning sessions, they are available on YouTube, on MDA's channel on YouTube. There's a QR code up here on the screen. We'll also put the link in the chat. Part 1 was focused on Duchenne and new treatments in Duchenne. The second part was about understanding insurance and the whole insurance process for gene therapy. And we also had a presentation from Dr. Barry Byrne about advances in gene therapy across all neuromuscular diseases. So we encourage you to check those out. Today's session is also being recorded and will be available for on-demand viewing in about 3 weeks. And with that, all phone lines are muted, cameras are turned off. We do encourage you to communicate in the chat if you have questions. We will definitely try to get to everyone's questions after the presentation, but feel free to enter those questions directly into the chat. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expand access to care and clinical trials through our care center network, and advocate for access and inclusion for the neuromuscular disease community. We deliver on this mission through research, access to care, advocacy, education, recreation, and engagement. It's now my pleasure to introduce our speaker. Dr. Veerapandiyan is a pediatric neuromuscular specialist at Arkansas Children's Hospital and an associate professor of pediatrics at the University of Arkansas for Medical Sciences. He serves as the director of the Comprehensive Neuromuscular Programs at Arkansas Children's Hospital. He's the co-director of the Muscular Dystrophy Association Care Center and director of the PPMD Certified Duchenne Care Center at Arkansas Children's. Dr. Panda earned his medical degree from the KAP Vishwanatham Government Medical College in India. He completed a residency in child neurology at Rutgers University, New Jersey Medical School in Newark, New Jersey, and a fellowship in neuromuscular medicine at the University of Rochester Strong Memorial Hospital. Dr. Panda has a passion for clinical research and education. He has published more than 60 peer-reviewed articles and has presented his work at national and international meetings. He's actively involved in industry-sponsored clinical trials, including gene therapy trials focusing on neuromuscular disorders in children. Thank you so much for being here today, Dr. Panda, and I will now turn the time over to you.
Thank you, Marissa. That was a lot of introduction from you doing that. But thank you all. Good afternoon. Thanks for joining. Let me share my screen and then we'll get started. All right. I think I was asked to kind of talk about what are the things that you need to know or ask your provider if you're deciding to pursue gene therapy for Duchenne or any sort of other neuromuscular disorders, not from a medical perspective. I know there was a lot of sessions that talked about gene therapy in detail. So from an administrative and then also like, what sort of experience that the providers need to have? Is this a right place for myself or my kid to have or to pursue this gene therapy? So feel free to turn all the questions in your chat and we'll try to get to that at the end of the session. And if any of this sounds more complicated, just feel free to ask me, put that in the chat and I'll explain it to you guys as well. All right, I think these are the objectives and I'm not gonna read through them. I'll just leave it here for a minute. It's just kind of talk about how the gene therapies are administered, like what are the different specialists, administrators involved, and also what questions to ask your healthcare provider, and also how to support patients in making informed decisions. All right, so this is sort of a gene therapy for DMD, and of course, there are SMA already had gene therapy that's approved, and then there are several other neuromuscular disorders where we have gene therapy in the horizon. And again, I'm not going to get into details. All we hear about is as fancy as one-time injection, one-time intravenous injections. But I want to emphasize here that it's not a one-time done deal, right? Yes, the injection is only one time, but it involves there's a lot of other, the safety monitoring and other things that happens after the infusion, after the therapy. So it's more involved than just one-time injection, and there's a lot of commitment that's needed from the families, from the patients, from the individuals, and also from the team that you work with. So I think that's what we're gonna briefly talk about today. Now, then this slide kind of talks about, there's a lot of therapies, just mainly focusing on Duchenne here. There's a lot of therapies coming up in the pipeline. There's gene therapy trials, and I know all of you will be discussing these with your primary neuromuscular providers, right? Now, the key is no matter what diseases, right? So we need to understand or establish our needs and goals of the treatment. For Duchenne, it's going to depend on which phase of, what part of the stage of the disease that you're at. Your goal would be different. So we all have to have realistic goal about what are we trying to achieve from this therapy. So have the discussions with the open discussion with your care provider, and before you proceed with any sort of therapy, have that expectations or goal established. I think that's going to help you in the long term rather than setting false expectations or false hopes. All right, I think, again, I keep talking about Duchenne here, but just in general, for most of the neuromuscular disorders, we all know about the multidisciplinary care that's needed because of a lot of our neuromuscular diseases involves multiple, not just your muscle, but multiple other organs, your lungs, your heart. So we know about this, right? But we're introducing this new concept of gene transfer therapy. So the gene transfer therapy has things like, we are using a virus to actually give you this synthetic microdystrophin. For in case of DMD and SMA, it's a different gene that you're giving, and the gene is going to be different for different disease. But then, sort of, you look at the vector or the vehicle that carries the gene is going to be mostly what we call AAV, adeno-associated virus. So we're introducing this, and we are seeing immune-related reactions. I'm sure you can hear, if you listen to those other webinars, you will hear more about that. So this introduces new challenges. So you need new expertise, new physicians to help us manage, because we are neurologists, right? So we are not trained to deal with some of these your body's immune reactions. So now we are learning, since we are having all of these advanced therapies. So you need to have other specialists involved in the care as well, in addition to who you are already working with in your multidisciplinary clinics. All right, so this is the first thing from a medical standpoint, right? So what do you need to have? What are the things that you need to know in a center that you're trying to get gene therapy from? So you have to make sure they have this, what we call a gene therapy team. So that gene therapy collaborative team. So no, you in addition to your regular multidisciplinary care doctors like neurologists or cardiology and pulmonology, maybe the rehab doctors who does work with equipment and therapies, you need more other physicians as part of that, other specialists as part of the team as well, like blood doctors, what we call hematology, kidney doctors, immunologists, and also hepatologists, liver doctors. So because we are seeing these side effects coming and affecting these organs from gene therapy, so you need to have this team in place first. Now you have to have these physicians, either they should have experience or expertise, or at least should be open to learn what's out there and kind of work closely with the team. So how does this team come into play? And a lot of times we utilize this team to even brainstorm if this kid or this patient or this particular individual is an ideal candidate to receive gene therapy, right? And of course, there are things safety issues that you have to assess the kid, the individual's cardiac status, breathing status, and all of that. Of course, we discuss that with the families, but you also have to discuss us with the team and like what are the things that could happen and how are we preparing for this specific for this individual patient. So you have to make sure that the center that you're going to has this multi-specialty team that's available, expertise that's available. Now, that's from a medical standpoint, right? But then also there's a lot of it's not just your neurologist or your neuromuscular neurologist who's is the only person that needs to be involved. It's a lot more than that. There's a lot of orchestration that needs to happen, right? You need to have your hospital buy-in, and they have to be supportive of us doing this therapy. So the center that you have to have, this is what happens in the background. I don't have to get into details here, but this is what's happening in the background, and you have to make sure that the center that are going to have this all of this had happened and they are ready to go, right? So as a neuromuscular provider or anyone in some places it could be a cardiologist, some places so we need one champion, right? It could be so that person starts engage in early discussions with the hospital leadership. You identify the stakeholders, like who are the important people in the administration level and the hospital level who I need to talk to make sure we can, as a hospital, as an institution, we are well equipped to provide this complicated therapy and even to our patients, and we can safely administer them and we can safely follow them. And some of these key people involve these top tier medical leaders, right? Like, chief medical officer, chief executive officer. Yes, this is there's several things that need to look at. Like, is it safe? Are we putting our patients in danger by delivering this? What are from a hospital side, what we need to decide to help us equipped to get to the point that we can deliver this gene therapy safely. So that's why we have to involve these. And then, of course, there's a financial piece that comes with this as well. Of course, when we talk to this stakeholders, we talk about what are the therapies in pipeline, why is it needed for our families, why do our hospital has to do that, when would this be available? We start these discussions at least a year ahead of time. If you're expecting an FDA approval next year, we start the discussion at least 12 to 18 months ahead of time. So your team, wherever you're going to, has to be equipped like this. They have to have this action happening in the background. Then of course, identifying appropriate teams. So just again, you don't have to know all of this, but you don't have to ask your providers about this, but just to keep in mind in your background, these are things that are happening in these centers who are engaging themselves or who are preparing themselves to do gene therapy, right? So they have to have their pharmacy team involved. They have to have their finance and billing team, the insurance team for prior authorization. This infusion is happening in the infusion center. There's a lot of nursing action happening there, right? So all of these teams need to be involved, and you have to do a lot of education sessions with them to get them prepared for this. And again, this kind of talks about what are the things that we talk about. How many patients are we going to dose? Where are we going to dose these patients? Are they going to stay in the hospital, or are we going to keep them close to the hospital? So all of these things we discuss. Again, all of this happening at least a year ahead of time. Then, of course, you have to have the hospital has to have a pharmacy that has experience in dealing with gene therapy preparation, storage, and and then there are other considerations as well. This is just an example of what are the things that we talk about in terms of educating the whole our team that's going to be involved in gene therapy. Now, it's also important to know that ask the center that have they had any experience doing research, doing clinical trials, with gene therapy, because that experience can help a lot with your clinical commercial dosing experience. If you have a research team who did, if you're a neuromuscular doctor, or if you're the center has experience doing research in the clinical in gene therapy, they can have a lot of their learnings can be translated into the clinical practice. Even though the teams are completely different, they can share their learning and understanding, and that will help a lot as well. So this is another piece of information that you can actually ask the providers. And then, of course, a lot of us would have, based on what we learned, we have a lot what we call standard operating procedures, like a document that or any of our staff can actually reach to that, get to that document and can understand what's happening. Now, again, this not so important, but I think it is. It's also key that you have to have a good information systems team, because a lot of centers now using what we call electronic medical records, right? So you enter the orders, everything in the computer. So let's say if I'm ordering it, if a physician is ordering something that's not right, you can already set in a warning in there. Hey, it gives you a warning. Whatever you're typing, whatever dose that you're putting in seems like it's too much for this patient. It also gives you warning if they notice any changes if the nurses enter your temperature or anything, and that's above that's not normal. It gives you warning. So I think this is also a critical piece to keep in mind. Now, I just want to give you just the overview of what's the process involved from an administrative standpoint for dosing. So again, this is a complicated process, and I think that's where when we talk to your the centers that you're planning to get treated, ask some of these right questions about the prior experience. Do they have a good prior authorization team? Do you have a gene therapy team? Or do you have support from your hospital administration? How is the safety monitoring being done and all of that? I want to kind of kind of walk you guys through what happens in the process. I'm sure you might have already heard this from previous webinars. And of course, we identify, our clinical team identifies a patient. We discuss with the family. We make a decision. Okay, this is we can move forward with this particular individual for gene therapy. Then we notify our prior authorization team and our pharmacy team. Then our prior authorization team works with the payer, and I, as a key provider, I get involved in a lot of this prior authorization process, because I need to talk to the payer, payers to help them explain and understand why is this medically necessary, right? Once we have an approval from the insurance, that doesn't mean you're good to go. I'm sure you might have heard this before. A prior authorization approval doesn't mean anything. The thing that happens after that is more important. Now, your hospital has to have some sort of agreement with the payer for the payment terms. So that's more important. So that happens right after the PA process is happening. It's what we call single case agreement. The terms differ. And once that had happened, then you get approval from our leadership. Then we schedule the dosing, and all of this happens in notify pharmacy. Pharmacy orders the drug, then we get the drug, then we notify the families, we schedule. This is what sort of a stepwise process that's happening. So I think just to show that I think when you work with your team, just have some patience in terms of they have to work through all of this, and if you have a lot more volume of patients that you have to work with, it may take a little longer time to work through this process. And I think it's extremely important we make sure that all of this happens. All of this happens in the right way, so we can dose. We can think about safely dosing the patients. Again, I think this is to bring back again. It's not just your one person, your neuromuscular provider or whoever that key person is. It's a lot of teamwork and orchestration and coordination. You have to make sure that when we talk to the center that you want to get dosed, they have all of these experience and all of this team and that orchestration happening there. You have medically, you have to have this gene therapy collaborative team, right? And then of course there's nursing team there. You have to, if they're doing it in the infusion center, you have to have that, the nursing team, or sometimes they do it in the inpatient setting in the hospital, so you have to have that. And of course, if something happens, right, so they need to have their emergency room physicians, the ICU physicians, all of them um, need to be aware of what's happening in terms of the gene therapy, what side effects could happen, and how to manage if something happens. Um, and then you also have to make sure that you have an on-call, you have a contact number for someone that you could reach to, who's actually directly you can talk to when something happens after hours or even during the day. So you can talk to, or if you go to emergency room, they have this, they have an idea about what's happening. So you have to make sure that all of these pieces are in place before you think about dosing or proceeding with the center. And of course, there's the leadership team that comes into play for procurement and administration, right? And there's a lot of dialogue that's happening between all of these different different teams back and forth. And of course, your clinic coordinator, whatever clinic that you work with, their clinic coordinator, the neuromuscular provider being the primary, or, he or she runs the whole thing, they being in the middle, and they have to follow up all this conversation, the process, and they should be communicating with the patients and families about what's happening. Again, this could be a neuromuscular provider. It could be, depending on what center you are, there are centers where cardiologists run the whole team. There are other centers, you have rehab physicians that run the whole team. So you have to, the providers may differ. So you have to ensure that there's that good communication happening, and you have a coordinator who's dedicated to work with the families when we do the scheduling and other things. All right, so this is sort of a brief overview of the process. I want to give more time for Q&As. But some of the things, again, that you could ask would be prior experience with gene therapy, right? Obviously, there are some centers that may not have prior experience with gene therapy, but they should be open to reach out to the centers that have prior experience. Even though if they don't have prior experience, I think you have to make sure that the expertise that's needed, like different specialists like cardiology, pulmonology, hepatology, all of those doctors have to be in place. Otherwise, I don't think it's safe to dose a patient with gene therapy if you don't have any of that in place, your other expertise in place. And of course, you can talk about clinical experience, commercially dosing, as well as research experience, like I said before, right? And then institutions, not just the team's experience, but the institution's experience overall. Have they had any gene therapy experience before, not in the neuromuscular space, in any other space? How successful they were? They had how what sometimes a lot of these hospitals may have experience in with hematology, like cancers, so those kind of stuff. Then of course, you want to make sure that, like we talked about, all of the gene therapy team and the specialists are involved, and they are there in the hospital to take care of you guys if something has to happen. And then discuss about the safety follow-up, right? So if there's, like we discussed before, there are centers that that recommends the families to stay close to the center for a few weeks. It could be 2 months, could be 3 months, for a close follow-up for the safety reasons. If something had to happen, you come back to our hospital so we can take care of you. So talk about that and how that being set up. You may be driving or to a center that's like 4 or 5 hours from where you live. If that happens, how is that going to work? Can they work with your local provider for safety monitoring? I think those are things that you need to ask before and have that squared away before you even proceed, right? Let's say if someone who's in the later stages of the disease, like non-ambulatory patients, or who are on skilled nursing care, home nursing, and if for them, if they have to go to a center that's like 6-7 hours away from where they live, then that's a whole, and they have to stay local, then that's a whole, it's a lot of challenge. You have to work on getting those skilled nursing care and everything there. So I think those are things that you have to discuss with that team that you're going to work with. And then you also want to make sure that, if you're going to a center that you feel like they're not equipped to do this. There are centers who openly would say, hey, yes, this is an option, but we don't have the expertise or experience to do that. And we should appreciate that and ask them where they would refer you for that, and would they be willing to work with that center once you get dosing. Talk about how the administration day looks like. When do you come in? Am I going to stay in the hospital? How long it's going to take? What sort of support that we get when we are here, and also what kind of support that we get afterwards, right? Is social work involved? Do we get support if you're staying locally? Are you able to? It's a hospital, or you're able to arrange that? The Ronald McDonald houses or other things. Are you able to arrange that? The stay for us. So those sort of information you can get from them. And then we already talked about the experience with insurance approval process, and I think that's a huge piece. You need to have a team that actually has experience and expertise in working with the payers to get these high-cost drugs approved. Then obviously working with the primary providers. It could be your primary care provider, or it could be a primary neuromuscular providers. If your center is referring you all to somewhere else, then it's, if you need them to be followed up locally for safety follow-ups, then they have to communicate with each other. These are some of the key questions that you can ask the providers before you decide. But I think, again, the things that I want to emphasize here is we all have to understand the complexity of the gene transfer therapy, right? It's not a one-time done deal. So I think there's a lot more involved from a medical standpoint, from a safety standpoint, from a patient and family standpoint, and also from a medical team standpoint, from a hospital administration standpoint. So all of them have to be aligned in place for this dosing, for the gene transfer therapy to happen safely. Importance of asking the right questions, right? Making informed decisions about care options. Don't afraid to ask these questions. Hey, how many patients you have dosed before? How was your experience with the payers? All sort of right questions I think you should ask, and so you can make more informed decisions. We have to empower families to voice your concerns and preferences, and again, be open and talk about it. Hey, since you haven't dosed any patient, or since you have dosed only 1 or 2 patients, I would really like to look at this other place. Have that, have the discussion, talk about the pros and cons with your providers before you make the decision. And of course, always there's support network that's involved. You can discuss with other families. I know there's going to be a panel, family panel that's going to happen right after this. Discuss their experience before you make the support group. There's advocacy organizations like MDA and PPMD. So I think, discuss with that and make that right decision in terms of where to get those. This is the right place for me to go. And I think that's all I had. I didn't have a lot of stuff to talk about, but I'm happy to take questions and have any sort of discussions. And I just want to kind of give you an overview of what are the things that's happening behind the scenes and how complicated it is. And you want to make sure that you understand that, and when you talk to your providers, you sort of get an idea about what's happening, and so it's so you can decide. So I can get myself or my kids dosed safely in this place. All right.
All right. Thank you so much, Dr. Panda. It was very helpful. A lot of really good things to think about and digest before moving into a decision like this. A couple questions here. Are there any red flags that people should be aware of when deciding where to go for treatment?
That's a good question. I think red flags in the sense if they don't have the team. If they don't have all the expertise, I wouldn't, I think that's most important, right? I wouldn't, have them dosed. Geographically, it may be convenient for the patients and the families to be dosed somewhere locally, but if I'm the only provider, that I'm the only one to work with, and that's a big no for me. And I think, again, like I said before, even if they don't have the prior experience, if they have those resources and the providers who are open to have the discussion with other centers, or even look at some of these resources and get experience, then I think that should be fine. But having just one provider, I think it's a red flag per se.
Sure. So not having that multidisciplinary approach,
Right.
having all the right people. Um, what about with gene therapy, you have to undergo a lot of specific tests and evaluations before
Mm-hmm.
treatment. Can you work with local providers to do those things and then go to a bigger center for treatment? How does that
So
work?
I think, yeah, I think that's a good question. I think in terms of, it's yes and no, right? We work with a center that's, for example, a center that follows boys with Duchenne, but they're not equipped to do gene therapy. So we get a lot. We get all of those patients from that center. So how it happens typically is they get the baseline labs, they get the antibody testing, and they come to me. It really depends on your physician that you're working with. For me, I need to, even though they had the discussions before, I would sit down with the family again, discuss the whole Duchenne from the beginning, gene therapy, the understanding, pros, cons, and before we proceed again. Now, for the safety lab work, I still repeat the test, so I have something in my system. And for the antibody testing, if it is done over 3 months, I repeat it. If not, then I would just use that. So that timing is gonna depend on which provider you're working with. But I think a lot of us are open to work with the primary care provider or your local neuromuscular care provider, as long as there's open communication.
Sure. Would you say the same for post-treatment follow-up, that can they work with like their local pediatrician or a provider to do any post-treatment testing?
So suppose follow-up is a little tricky, right? Because there's a lot of more frequent labs that's done, and some of those you need to have the reports immediately, like same days. So if anything happens, you have to act on that. Maybe you have to change the dose of steroids that they're on. You have to bring them to hospital to see. So I think that's a little trickier. I prefer to have them stay with locally and follow with me for those 3 months, to safely dose them. I think, and then there also you have to discuss that with there are some labs that may not be available at the place, like special the troponins. If we talk about, we focus on the troponin, high sensitive troponin. There are some hospitals won't do that. Some hospitals won't get the turnaround time of getting that report maybe a little longer. So you have to keep that in mind when you discuss, when you think about coordinating the follow-ups with local providers.
Sure. Well, that makes sense. We had a question come in. How long does it usually take from the initial consultation to receiving a dosage?
That's a good question. It really depends on the center, depends on there's a lot of factors that come into play. But if you, I have had an average, I would say a couple of months. But I've had patients that I've dosed from initial consultation, even dosing within a month. I've also had some, the later in like 3 months. So it really depends on how good we can communicate with the payers. I think that's a bigger challenge. And then once you order the drug, procuring the drug also sometimes it can take a long time. It can take up to a couple of weeks to get the drug.
Do you know why that is? Like why it takes so long to get the drug?
It's just I think it's from the manufacturing, or it takes about a week. sometimes. It used to be 2 weeks. Now I think it's getting better, at least for elevators that I can talk.
Gotcha. Okay. Another question came in, is gene therapy often covered by medical insurance, or is it still considered experimental?
So that's also a great question, right? So when I'm going to tell, I think, for example, elevators for Duchenne, right? When they initially had approval for age 4 and 5, our experience overall was pretty good. I think since the volume of patients that we're working with is so low, I think it wasn't really difficult for us to uh, to get the approvals. But now it's different with the expanded label for everyone, for all boys with Duchenne. So some companies, there's two different types of approvals, right? So there's your full approval, meaning FDA looks at the dystrophin expression and also the functional data, like the motor outcomes data, and there's a full approval. So right now for Duchenne, ages for all ambulatory boys that are walking, it's a full approval. Meaning it's a traditional pathway, looked at both the dystrophin data and the motor outcomes data, and it's full approval. Whereas for non-ambulatory boys, for Duchenne, it's an accelerated approval. What does that mean is the approval is mainly based on some sort of biomarker. In this case, it's dystrophin expression that is reasonably that can predict functional outcomes. So a lot of companies, when you have this, what we call the accelerated approval, they consider that as investigational, and they don't pay. When you have full approval, usually they don't. Now, sometimes what we are seeing here is recently the payers are not aware of the expanded label, and they're not aware of what's full approval versus what's accelerated approval. So they kind of come back and say, hey, this is investigational. So we have to make an extra step to call them and talk to them, hey, this is the FDA approval and this is the process. So to simply answer the question, it's some companies in some instances are still saying it's some payers in some instances are still saying it's investigational, but we have to do that extra step.
Are you seeing that it's becoming easier with insurance or about the same?
It's getting harder now with expanded label. Yeah.
Okay. Interesting.
Because
Go
of the
ahead.
volume, right? They're seeing more volume come in, right, for prior authorizations. And with 4 and 5, the volume wasn't huge, I think, and now they're seeing more volume in Duchenne. I think that's what it is.
Sure. And I would just suggest to viewers out there, we did do a presentation all about navigating insurance for gene therapy, and we could put the link up in the chat to that presentation. And MDA also has kind of a cheat sheet, or not a cheat sheet, that's not a good word, but a guide, I guess, to how to navigate through the insurance process. So we'll pop those things in the chat as resources for you. We are getting a lot of questions in the chat about gene therapy being available for different diagnoses, LGMD, IBM, CMT. I know we asked you to speak more about what questions to ask your provider, but are you able to shed any light on just what might be coming down the pipeline and what might be?
Yeah, I think I see the questions. I'm not sure about the IBM. I have to look if there's any sort of gene therapies coming for IBM. But definitely for limb girdles, different types, R1 and then FKRP, the 2I. There are therapies, the specific subtypes. Some of them are in phase 2, phase 3 stage, and some of them are in phase 1, meaning still in the safe, so looking at the safety, and some of them are the preclinical stage, even before the clinic, even looking at the animal studies. So they are coming, and CMT is also there are gene therapy programs that are under pipeline for CMT, especially CMT type 1A. So I think there are in the pipeline. They are in the pipeline. I think I just can't. At different stages now. I just can't predict how long it's going to take for them to clinics.
And would you suggest that people go to like clinicaltrials.gov to see what's there and how they could get involved, or?
Yes, so clinicaltrials.gov would be a good one. I'm sure there are other like limb-girdle focused patient advocacy groups post, updates on the research and clinical trials on their website, and I know MDA has that as well. So I think those are all good places to keep you updated. And feel free to talk to your neuromuscular provider. I think as a part of our routine clinic visits, we should be able to give you updates on, hey, what's happening. If this is a trial that if you're interested, we are not doing it. If the other site is doing it, we should be able to kind of at least give you that information and discuss that.
Sure. And we'll pop the link in the chat to clinicaltrials.gov. MDA also has a clinical trial finder tool that we will put in there. Somebody asked also about gene therapy for SMA. Do you want to share a little bit about that?
Sure. What was the question? I think, for SMA right now, it's actually in the United States, at least, it's approved. Zolgensma, intravenous Zolgensma is approved for two and less than 2 years of old and babies with SMA. And I think almost all states now do the newborn screen, and it's available. And then there are also studies are undergoing for what we call intrathecal gene therapy given through spinal tap for SMA patients that are older than 2.
Okay, that was going to be my next question. I know I've seen several questions pop in about adults, and is gene therapy going to be a possibility for adults? So,
Depends on the condition that we're working with, right? I mean, right now for Duchenne, at least, it's approved for everyone, right? It's approved for adults also. Of course, you have to discuss with your provider in terms of what's known, what we have right now, and what are the risks and benefits. But I think that's something to keep in mind. For CMT, and the initial studies they're happening in the adults also. For CMT, I think there's some types of limb-girdle muscular dystrophy also. Studies are happening in the adults. And I think to talk about the myotonic dystrophy, I think there's also some genetic approaches for myotonic dystrophy that's also happening in the adults. So there are some neuromuscular conditions where the gene therapy trials are actually happening in the adults before kids.
that is exciting to hear.
And that's also for FSHD, the facioscapulohumeral muscular dystrophy.
Okay. Okay, great. Let me just see here if I know there are some very specific questions, and I'm sorry that we can't get to all of them in the chat. I definitely would encourage everyone to speak with their medical provider if you need help finding a care center, an MDA care center. Our resource center is available to help you. We have specialists that can answer your questions within sometimes the same day or within a day and help you find the resources and information that you need. We also have our other presentations from this series that might be helpful. So just looking at a few more things here. Sorry, just scrolling through.
There's specific questions about comparing gene therapies and stuff, and I'm we can talk. I'm happy to talk to you offline if we want to, email me share my email with them. I'm happy to talk to them offline and talk about the trials and therapies and everything.
Sure. Okay. Well, thank you. That's very generous. One question came in about, is it recommended that boys age 5 and up be on heart protecting medication prior to gene therapy? Assuming this is speaking to Duchenne mostly.
Yeah, I think so. So as of right now, that's not been the practice. Right now the standard of care guideline says around age 9 to start the heart medications prophylactically, and now we are seeing that that's actually going down. We're starting even early, like around 7 or 8, unless you see 7 or 8. But if there is an abnormal echo or cardiac MRA before that, then you can start on cardiac medications. But nothing, I'm not aware of any recommendations specifically before gene therapy.
Okay. Another question, this one actually came in before the webinar. If you do CRISPR treatment on one gene, are you allowed to ever do treatment with CRISPR or gene therapy ever again? So I don't know if you can speak to
Oh,
the
that's the more,
possibility of doing more gene therapy or.
yeah, I think, from a gene therapy standpoint, the redosing is always something that we've been talking about. Redosing meaning, can we dose them again with this gene therapy a few years later, right? The challenge there is, even if it is a CRISPR, if they're going to use the AAV vector, so your body is going to have that antibodies to that vector, and which would make you the therapy ineffective. Now, could there be a possibility of, if you use a different vector and you can redose with another gene therapy in the future? It's possible, but we don't know. That's why there's been studies that are happening now in the animal models to look at redosing, or even kids who already have antibodies to those vectors, to see if we can mitigate that and help with redosing part. Those are nice questions. I think redosing is something, dosing again is something that people are thinking about it, and there's a lot of work that's happening right now.
Yeah, definitely. All right. Any other questions, please feel free to put them in the Q&A here. People asking if we can share your email. I can certainly do that. You're okay with that? Okay.
Yes, I can. Is that, if I put in the chat,
Yeah,
are they able to see
sure.
it, or it has to be in the Q&A session?
No, people should be able to see it in the chat. We can put it in there. Can you speak a little bit to some of the side effects or adverse reactions that people should be aware of when it comes to gene therapy?
Sure. Yeah, I think so that's a I'll briefly say about the side effects, right? So so the thing that the most common that you hear about is nausea, vomiting around the time of infusion, or within for a day or two, fever, nausea, vomiting, right? And then within the first week to two, you see something called myocarditis, which is the inflammation of the heart. Boys with Duchenne already have heart problems, and this is actually even on top of it. They can have inflammation of the heart, myocarditis. That usually happens within a week to two. And then there's another thing called thrombotic microangiopathy. It's also an immune reaction affecting the kidneys that can also happen within the first 2 weeks. Now, you have to keep in mind the different programs have different safety profile. Like Elevidys, we haven't seen the kidney part that I just talked about, but there are other programs that have seen that. So that's to keep in mind. About 4 to 6 weeks after infusion, you see what we call liver injury. There's inflammation of the liver, and then the liver enzymes go up. But this is sort of a common, a typical trend that we see. So what happens is the first ones that you see, like, the myocarditis, the liver injury, all of this is your body's immune reaction to the virus, the vector that's being used, the adeno-associated, the AAV virus, right? There's something called immune-mediated myositis, which is inflammation of the muscle itself. That happens about usually about 8 to 12 weeks after the infusion, about 2 months after the infusion. And what we have seen so far is that it usually happens only in Duchenne boys with exons 8 and 9 deletion. And that's why that's a contraindication in the label. We don't dose them. So that the myositis is actually an immune reaction to the microdystrophin itself. It's not to the vector. It's to the once your body makes this microdystrophin protein, there's a reaction to that. So what happens is your muscle reacts to it and gets more weaker than where you started. And it actually makes you more weaker, needing more immunosuppressive treatments. So this is sort of a brief what we know so far. And of course, there are other unknown things that could happen that we don't know about. And of course, Pfizer had a death in their program in an older non-ambulatory boy because of a heart problem. And another program, CRISPR had CRISPR with exon 1 deletion had a death also recently. There are some fatal events that you would hear. And we use this prophylactic immunosuppression, prednisone, on top of whatever steroid that you're already on to possibly prevent these side effects. But we have to be extra careful when we dose, and that's why we do this blood work more often. We see you more often the first 3 months. Does that kind of answer your question?
Yeah, I think so. I think that gives a very good overview. MDA does also have some print-ready handouts on some of this as well, that we can share and put in the chat. All right. Well, I think, I know we didn't get to everybody's questions. Some are very specific, and we wanted to really focus today on how to help you be prepared, and what questions to ask your provider as you consider gene therapy. And I think, Dr. Panda, you gave us a lot of really good things to think about and know, and help our families be their own advocates there. I want to thank you again, Dr. Panda, for sharing your time and your expertise with us.